MRCEM OSCE course, preparatory for the Royal College of Emergency Medicine, UK OSCE exam. Website www.mrcemoscecourse.com. Facebook page MRCEM OSCE course.
Hello dear colleagues, this is Mohammed Abdul Ghani Siddiq, co-founder and instructor of MRCEM OSCE course. First, I would like to send my congratulations to all our colleagues who passed the recent June 2018 MRCEM OSCE exams, which was held in London and India. Also, I would like to take this opportunity to announce for our upcoming 2 MRCEM OSCE courses, which are planned to be held in Riyadh in the last week of October 2018 this year, and in Dubai in the first week of November this year as well. Let's get to our topic today. Actually, this topic, according to my knowledge, has not appeared in the MRCEM OSCE exams before. But I have 2 genuine causes to discuss it today. The first one, that according to the trend of the Royal College of Emergency Medicine, that every 2 to 3 exams they will bring brand new station, so to be prepared. And the other cause, that it is relatively common emergency department presentation, and emergency medicine physicians a little bit struggle in approaching this case. So I will speak today about cerebellar examination. The expected scenario of a patient presenting to the emergency department with dizziness, and your task is to take brief focused history and then perform cerebellar examination. After that, to formulate management plan with the patient. So the pie chart will be largely of examination, and there is limited area for history and clinical reasoning as well as communication skills. So once you get inside the room, wash your hands, introduce yourself to the patient, confirm his name and age, offer painkiller if needed, call for chaperone, and take consent for your examination. Then ask the patient about the cause of his presentation to ER. How can I help you today? So the patient will tell you that he has dizziness, that he has spinning sensation. Then you need to ask just few focused questions because there is no time. So I will ask about the D's, I mean diplopia, dysarthria, and dysphagia. So I will ask him if he noticed any double vision, if he noticed any recent change in his speech or difficulty in swallowing. Then I will proceed to start my examination. I will start by asking the patient to stand up and putting his feet close to each other. Preferably, let him stand on bare feet and assess his stability while standing up and his eyes open. If the patient becomes unsteady and he is near to fall, this indicates cerebellar ataxia. Then while in the same position, ask him to close his eyes. Now I will assess the Romberg test, and if the patient is near to fall or already falling down, this is considered positive Romberg test. So whenever you perform this test, please be beside the patient or his relative, if there is a relative, to prevent falling and injury. And sometimes the patient might just swing a little bit. This does not consider a positive test. But if the patient is really unsteady and he is near to fall or falling, then you can call this positive Romberg test. Positive Romberg test does not mean cerebellar ataxia, but it means sensory ataxia. It means that this patient has proprioception problem and that he has a problem in the posterior column of the spinal cord, where we can find the gracile and connuate tracts. This is basic neuroanatomy. So I have two, the most important two causes of positive Romberg test or positive sensory ataxia are vitamin B12 deficiency, and the other cause is the rare neurosyphilis. So I will expect you, if the patient has positive Romberg test, to at least do complete blood count to look for features of megaloblastic anemia caused by vitamin B12 deficiency. So low hemoglobin and elevated mean corpuscular volume. Okay? Then let us proceed. Then I will ask the patient to walk and until the end of the room, and I will observe his gait. If the patient becomes unsteady and again near to fall, now this patient has cerebellar ataxia. Then ask the patient to turn and walk towards you, but this time ask him to walk with his heel to toe. Ask him to walk, but the heels just in front of the toes. This is to assess the tandem gait. So we'll assess the tandem gait by asking the patient to walk heel to toe. If the patient has cerebellar ataxia, it will be very difficult, if not impossible, to perform the tandem gait. Okay? Now I will let him sit down and assess if he is comfortable, and I will start from up. I will assess his eyes for nystagmus, both spontaneous nystagmus or induced nystagmus when you ask him to follow your finger. So I will assess for nystagmus and the gaze. Ask the patient to fix his head and then to follow your finger to both sides horizontally and then vertically. If the patient has horizontal nystagmus, assess the direction of gaze. If the patient has unidirectional nystagmus, that means the patient might have peripheral vertigo, but also we cannot exclude central causes. But if the patient has bidirectional nystagmus, then this is a strong indication that the patient has central vertigo. Then assess If the patient has vertical nystagmus, again this indicates that the patient likely has central vertigo. Okay? Then assess the speech of the patient. Ask him to repeat after you. Tell him that, please, can you repeat this sentence? British Constitution. British Constitution. Then ask him to repeat also baby hippopotamus. Baby hippopotamus. If there is slurred staccato speech, this indicates central vertigo or central cause cerebellar ataxia. Okay, so now we assess the eyes and we assess the speech. Now we will assess the coordination. First, we will start in the upper limb. We have two tests to perform here. We have the finger to nose test. Please make sure to perform this test in both upper limbs, not in only one side. Ask the patient to touch his nose and then touch your finger while you are moving your finger horizontally, and observe for any post pointing, for any overshooting or undershooting if he cannot reach or he passed your finger. This is called dysmetria. So you can add this D to the previous D's. Then assess for this dyadicokinesia by asking the patient to perform alternating movements by one hand over the other, to touch the palm, for example, of the fix the left palm up, and then by the right hand make alternating movement and touch the other palm by the palmar and dorsal aspect of the right hand, and then repeat in the other hand. This is called dysdyadicokinesia. If the patient failed to perform these movements, then likely he has cerebellar ataxia. Then go and assess for coordination in the lower limb. We have one test here, heel, knee, shin test. So while the patient is lying flat on the couch, ask him to bring the heel of one foot and touch the knee of the contralateral foot, and then move the heel down over the leg until the shin or until the ankle, and then repeat the same movement again for 3 or 4 times, and then repeat on the other side. Heel, knee, shin test. If the patient cannot perform it, so likely he has cerebellar ataxia. Then assess the tone in upper limbs, and also if there is time and you are quick, assess it in the lower limbs, and assess reflexes. In cerebellar ataxia, there will be hypotonia and hyporeflexia. So by now, we almost completed our cerebellar examination. So I will mention that I would like to do special tests, and it depends on the situation. So we have the Dix-Hallberg test to assess for paroxysmal positional vertigo, and also we have Hinz test HINTS test, to assess for central causes of vertigo. So the Dix-Holbein test for assessing for the benign paroxysmal position of vertigo, we perform it only if the patient is asymptomatic and there is no nystagmus. I will repeat again, because this is a common mistake that every patient coming with features of vertigo, some of our colleagues perform the Dix-Holbein test, which is inappropriate, because it might exacerbate the symptoms for the patient and make things worse. So if you have a patient and he presenting with severe dizziness, likely with frequent vomiting, don't perform the Dix-Holbein test to assess for benign paroxysmal position vertigo. If he has nystagmus, don't perform the Dix-Holbein test. Only you will make the patient suffer, and if the patient suffer, you will suffer. Okay? So you can review the YouTube to see how we can perform the Dix-Holbein test. So I will perform it only if the patient came with history suggestive of benign paroxysmal positional vertigo. And if the test turns to be positive, then you can perform the Eble maneuver to correct the problem. Eble maneuver. Okay? But on the other hand, if the patient came with vertigo, spinning sensation, and he mentioned, or during your examination, you notice that the patient is stable and there is no nystagmus, then you can now proceed to perform the HINTS test, HINTS, which stands for head impulse test, nystagmus, and test of skew. So the H and I, head impulse test, N for nystagmus, T and S, test of skew. So you can just mention that in the exam, but for real life, the head impulse will be performed by holding the patient face. First, make sure that the patient has no problem with his cervical vertebrae, and then hold his face by your both hands while you stand in front of the patient, and explain to the patient what are you going to do, and then move the head horizontally to 20 degrees to the right and left, and ask the patient to concentrate in one point, for example, your nose, and then after turning the head laterally up to 20 degrees, quickly rotate it to the center while observing his eyes. If you notice that the eyes moves or does not return back to the center, I mean your nose, immediately, or it remains in the center. So, for example, the eye moves up and then return back to the center. This is a good sign, by the way. It means that the patient has vestibular disease, and this is peripheral vertigo. In central vertigo, actually the test will be negative. Head impulse test will be negative, and the patient can concentrate on the center or in your nose all the time. Nystagmus, we already discussed it, and test of skew, or the other name is cover-uncover test. You can perform that while asking the patient to concentrate in front of him in one point, and then by your hand cover his right eye and then quickly the left eye, and then alternate between the two eyes, and pay attention to his eyes if they move when you remove your hand from, for example, his right eye. If the eye moving up or down, this means this patient has central vertigo. You can find many videos in YouTube regarding his test. So by now you should have completed your cerebellar examination. Thank the patient, and you can now formulate the management plan accordingly. If the patient has features of only peripheral vertigo, you can reassure him. If the features suggestive of benign paroxysmal positional vertigo, then what you need to do is Dix-Hallberg test and then Abley maneuver. Also, if features of peripheral vertigo but of vestibular disease like vestibular neuritis or Meniere's disease, then you can refer him to the ENT dizzy clinic for follow-up. But if you are concerning about possibility of central causes of vertigo, then you should proceed to perform brain CAT scan and even CT angio or MRI, and consider neurology consultation. So let us summarize. The station will be of cerebellar examination. The patient presentation to ER will be of a patient with dizziness. First, make sure that he means, what does he mean by dizziness? Is it unsteadiness or spinning sensation? And then proceed by taking focused history, ask about the D's, and make sure you document it in your chart. Diplopia, dysarthria, dysphagia, and then in your examination, dysmetria, the finger to nose test, you should also document it. Then proceed to your examination. Start by assessing the patient stance, his stability while standing up, opening his eyes. If the patient is unsteady, this is cerebellar ataxia. Then assess the Romberg test while asking the patient to stand and his feet close to each other and closing his eyes. And if positive, this positive Romberg test indicates sensory ataxia, gracile and conjugate problem, proprioception problem, and the most common causes are vitamin B12 deficiency and rare neurosyphilis, do CBC. Then assess the gait and then the tandem gait. Then assess the speech and assess the eyes for nystagmus, horizontal and vertical nystagmus. If horizontal and unidirectional, this is usual presentation in peripheral vertigo but does not exclude central. But if bidirectional nystagmus or vertical nystagmus or rotatory nystagmus, this is likely central cause. Then assess coordination, upper limbs, by assessing the finger to nose test and also dysdiadochokinesia. Then assess in the lower limbs the coordination, the heel knee shin test. Then assess for hypotonia and hyporeflexia, which indicates cerebellar ataxia. Then consider special tests. If the features consistent with peripheral vertigo and there is no nystagmus, then perform the Dix-Hallpike test, and then you can perform also the Epley maneuver if that one is positive. But if there is nystagmus, then you should consider the HINTS test, HINTS, which stands for head impulse test, nystagmus, and test of skew, or the cover and cover test. Then discuss the management plan with the patient. That is everything about cerebellar examination. Goodbye. See you soon.